I would like to begin to welcome Dr. Saeed Alqahtani to start with the strategies for radiation dose optimization.
Thank you, Doctor. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah, alhamdulillah, wa salatu rasulullah. Okay, here it's me again. Okay. Yesterday we had a talk about high-risk patients. Who was attending yesterday? Who attended the session yesterday? Could you please raise your hand? Okay. So, the moderator, if you don't mind, I will deviate for a minute from the talk. I will get back to the topic that we talked about yesterday. Our topic today is regarding dose optimization. I will just give you the agenda, and then we will go back to the shielding issue that we had a conversation about yesterday. We will talk about radiation dose quantities and what does dose optimization mean? Is it dose reduction? Is it image quality? Is it both? We need to figure out some hints and tips, because I know everybody is here practicing in clinical practice. So I assume you are more expert than me in this area of practice. And also we will sum up with some tips that you can follow to do your own assessment to advance and improve the clinical practice in your department. And then we'll sum up with take-home messages. So we'll get back to the shielding yesterday. Here is, for the one who didn't attend yesterday, we had a discussion regarding should we use shielding or not? And based on the literature, we should not use them anymore for the patients. And when I say for the patient, I mean if you have a patient, whatever the patient, pediatric, pregnant, normal adult, any patients, and you are doing, for example, chest X-ray or abdominal X-ray, do not use shielding on thyroid or on the gonad system. Based on the literature, they are useless. We had a conversation 5 minutes ago regarding we need to understand the mechanism of the scatter radiation. And if you understand the mechanism of scatter radiation, especially in diagnostic, you will be convinced that shielding will not add any value to dose reduction. So this is one of the meta-analysis. And if you look here, our study demonstrated that the current practice of gonad shielding during female pelvic radiography should be no longer considered as an effective method to reduce radiation exposure. Here is another article. If you look here, the American Association of Physicists in Medicine issued a position statement laying out the recommendation that gonad and fetal shielding in medical imaging be discontinued. So we don't use them anymore. And this is a systematic review that's included around 400 articles around this topic. If you want to get to this paper, you can just scan the barcode here, go back home and spend some time reading the article. Okay, is that clear? I hope everyone will be convinced after you read all of these articles regarding shielding in radiography. Okay, regarding our topic today, we need to understand radiation dose quantities before we talk about dose optimization in any kind of patient, in any kind of modalities. We need to know what kind of radiation quantities we are dealing with, because there are so many. Can anyone give me an example of radiation dose quantities that you are aware of or you are familiar to? Absorbed dose? Anything else? Equivalent? Effective? What else? Okay. CTDI, DLB, DAB, CTDI, volume, CTDI 100, all these kind of quantities, okay? But when it comes to dose optimization, actually they are index. That's why CTDI is CT dose index. Dose area product. None of them is absorbed dose. And even though absorbed dose itself will not help when it comes to dose optimization, we need to look at equivalent or effective dose, or what do you think? What's the most important quantity when it comes to optimization? See what it is the unit. But what's the dose? Absorbed dose? Effective dose. So the effective dose is the quantity that will take into account type of radiations, because gamma is different to X-rays, different to beta, to alpha, okay? With the effective dose, we take into account the type of radiation, and also we take into account the tissue weighting factor, the radiosensitivity of the tissue, okay? With absorbed dose, we just measure the absorbed dose, that's it. Whatever the dose is, whatever the material is, we don't care about them, okay? Do we get absorbed dose in CT or in radiography? Do you get these numbers? No. How can we do absorbed dose? Sorry? Okay. How can I calculate or how can I measure the absorbed dose? So we need at either a phantom, anthropometric phantom, like RANDO, or Monte Carlo simulation. We cannot do absorb dose on a patient at all. We can convert intraskin dose to absorb dose, but we cannot at all measure the absorbed dose on a patient. So, this is what we talk about is, at the beginning, equivalent dose, absorbed dose, and effective dose. Effective dose is the one that is important when it's come to dose optimization. We have some index. For example, in radiography, we have something called dose area product, and that's the total radiation to air multiplied by the area of X-ray field. It's not absorbed dose, it's not effective dose at all, but it will give us an indication the output of the tube. We have CTDI and CT scan. This will be helpful to compare scanners, to compare GE to Siemens to Canon, so on and so forth. We have CTDI volume, and that is radiation per slice and reference phantom, either pediatric phantom or adult phantom. There's no absorbed dose, there's no effective dose in CTDI volume. DLB, it's CTDI volume plus the scan length. But again, there is no absorbed dose or effective dose. We can use SSTE to measure the absorbed dose with the patient size considered. We can convert that one into effective dose. I will come at the end, I will show you how to do effective dose measurement. So these are the quantities that we can use when it comes to radiation dose optimization. But what does dose optimization mean? Does anyone knows? When we say dose optimization, does it mean dose reduction? Any idea? Okay. Basically, we need to get the best image quality or the diagnostic image quality, okay, with the lowest dose. We don't need the best image quality, we just need the diagnostic image quality. That will give us a diagnosis. Sometimes you don't need a very high or very top image quality. You just need an image. For a body, it will be easy to detect them. Okay? So bear in mind the indication, what you are looking for. Do you need high image quality or low image quality? Because if you need high image quality, the dose will be high. That's normal. Okay? The radiation dose, as we said, is the effective dose. The absorbed dose has no meaning when it comes to radiation dose optimization. Image quality. How do you assess image quality? How do you say this is good image quality? Does anyone know? We have subjective assessment. The radiologist will look at certain areas in the image and say, no, this image is not good. Okay? This is subjective assessment. It will be different from one radiologist to the other. Okay? And we have something objective assessment. That's something physical, numbers we cannot change, like SNR, signal to noise ratio, contrast to noise ratio. These are the criteria that we are familiar with. There is some sort of criteria which is quite new to dose optimization. It's called figure of merit. So what does figure of merit mean? The image quality divided by the dose. The highest the figure of merit is the best protocol. It will give you the highest image quality with the lowest dose. Okay? So let's have a look at some hints and tips when it's come to head and neck. And before we dive in, what are the organs that's quite sensitive in head and neck? Eyes, lens, and thyroid. Okay. So the first thing that we're dealing with when it comes to head and neck imaging or any imaging is the beam energy, which is KVB. That is the starting point. If you spot on the KVB correctly, then everything will be fine. Because that's the beam energy. That's the power of your beam spectrum. Lower KVB yield better contrast for bone and iodine. Are you looking for bone or looking for contrast? Then lower KVB. If not, go higher, 100 and above. Noise will increase, that is normal. With low KVB, there will be more noise. Increase the vascular enhancement. If you are after vascular, then go with lower KVB. Set your protocol based on indication. You should have many protocols based on indication. So for each indication, we will have different parameters, KVB, MAS, and so on and so forth. Photoinfluence, or MAS, milliampere per second. Is that the quality or the quantity? When we say MAS, is it quality or quantity? Quantity. And the quality? KVB. So keep it simple. Always remember that. KVB, quality, power. MAS, quantity. How many photons? Okay? There is a direct relationship between MAS and the dose. When you increase it by 50%, the dose will increase as well. Source of noise in CT is the quantum model. That is number of photon incidence. With low MAS, you'll have more of that noise. Think of using AEC. Always use AEC. It's there to help you. Use them. Restrainer measures. Does anyone know any restrainer measures that we can use in CT? Collimation. That's one of the restrainers. Collimate. Collimate. Always collimate. You don't need to go 1 centimeter above the area that you need to image. 1 centimeter will make a huge difference in dose reduction. Table speed and the pitch size as well. Does anyone know what does this collimation called? Anyone know? What is it? That's automatic shielding blades. Okay? Don't go post or pre. Just stick with the area of interest. If you go post and pre, that's what you'll get. You'll get more radiation to the post spiral. Okay? But if you stick with the collimation or with the area of interest, you won't get that. Automated tube current modulation. I'm sure everyone is familiar with this. Because it will give you the MAS based on that couch. So in some slice, you need more MAS, some slice, you need less MAS. So keep it on. It will do the job for you. Yes, it will need couch, but we do couch all the time for CT scan. Regardless of patient size, it will help you. Can reduce up to 52% of the dose. Image reconstruction algorithm, we have so many of them. Okay, so always use them. Always use them. We have iterative reconstruction and we have analytical, one like the Fourier reconstruction algorithm and filtered back projection algorithm. I'm not going to talk about the mechanism of them, but please use them. They are there in all CT scanners. Does anyone have any idea how to reduce the lens dose? You're practicing. You have patients every day. Give me your experience. Okay. We are talking about CT because the dose in the CT is quite high. Yes. Angle. Okay, tilting. That's good. A prone position. Okay. Okay. Okay, patient positioning. That's good. Here is one of the tricky and very easy protocol, which is, as our colleague said, tilting. Look at this. Do you think this will harm the patient? Tilting just a few degrees to the back. That won't harm the patient. That won't cause any discomfort to the patients. But we saved the dose by 89%. The eye dose or the lens dose. It cost zero. Don't have to pay anything. Don't have to ask the patient to do anything that will make the exam very hard for them. And there was no loss of image quality at all. Consider the following. Patient comfort. Always, if the patient is comfortable in the scanner, then there is a high chance that you will finish the scan with no error at all. If the patient is uncomfortable, you might repeat the exam again. Okay? Patient communication. How many times did you hear this patient communication? How many times did you hear it yesterday and today? A lot. Okay. I have a question. Does anyone have a protocol in their department for patient communication? A written protocol? No. Do you think it's time to have one? I think it is time to have one. Because you have so many different patients. You have pediatric patients, you have adult patients, you have patient who speak your language, you have patient who doesn't speak your language, you have deaf patient, you have patient with emotional issues, and all these sort of patients. So I think it's time to have a protocol for better patient communication because it's a key point. It's a key point. That's why you have had patient communication so many times.
Sorry for the interruption, doctor. 2 minutes left.
Okay. Keep eye on the patient. Always keep your eyes on the patients during the exam. Keep eyes on the patient. Make sure the patient is in the right position. Make sure the patient is comfortable, feel relaxed. The positioning is still the same as you position the patient. Keep eye contact with the patient. Positioning and immobilization, as the moderator said as well, Positioning is a key role in reducing the repeat and the retakes images. Always audit your protocol. You can change. Don't stick with one protocol for 1 year. You can change it every month. Do auditing. Do auditing. And whenever there is a possibility to improve, improve it. Do you have DRL? Do you stick with DRL? Sometimes. Okay. DRL is a key measure for dose optimization. You should have your own DRL in hospital. You have local one, and you have national one, and we have international one. So please, try to establish one in your department. Not just general DRL, but also indication-based DRL, size-based DRL. Do your own dose assessment. Here's some tips to do your own dose assessment. Collect data. Collect the dose data that you have in the scanner there, CTDI, DAB, along with the patient demographic. Compare scanner dose. You can do a very simple comparison between the scanners. The CTDI in this scan is higher than this scan. So we should do something. Okay? Consider different radiologist preferences. Some seniors, they want to look for a good image quality. They are fine with any image. So there's no need to go with high image quality. Use Monte Carlo. It's very easy one. It's not magic, it's very easy one. You can go online, use Monte Carlo, compare your scanner, compare the protocol that you are using, and then change the practice. This is a very simple one that you can convert CTDI into effective dose. And based on that, you can say, yes, this is a good protocol, this is a bad one.
Thank you so much for the wonderful information.